Sorry. The presenting author would be Dr. Parimita Datta.
Good morning, respected members of the panel. Here I am to present a tale of two cases of OSSN, ocular surface squamous neoplasia, one true and one mimicker. Coming to the first case, that is a 56-year-old male who was HIV positive, presented with a painless, gradually progressive mass for about 3 months. Now this is the picture where we can see that a mass was present in the temporal limbus with underlying flat placoid base and overlying leukoplakia with fimbriated margins covering about 10 to 6 o'clock hours of the limbus with no overlying keratin and pigmentation. So how did we manage the case? Intersegment OCT was carried out that showed a typical picture of OSSN, and after that, since it was the first presentation and involving up to 4 clock hours of the limbus, therefore wide surgical excision with cryotherapy of the margins and AMT was done, and histopathology was sent. Histopathology showed a typical picture of well-differentiated squamous cell carcinoma. Post-operatively, the patient was managed on topical interferon alpha 2B drops, 1 milli-international unit per ml 4 times daily for a period of 2 months. So these are the follow-up pictures at 2 months and at 12 months post-op, where we can see a clear ocular surface nicely reconstructed with no recurrence. Patient is doing good. So this is the case 2, a 65-year-old male with chief complaints of watering, burning, diminution of vision 1/16 in right eye and 6/6 in the other eye, with no prior history of trauma, ocular surgery, or any other ocular surface disease, but had history of thyroid disorder. So this is the presentation where we can see a pseudopterygium in the nasal half of the cornea and conjunctiva from 2 to 5 o'clock area. And in the other temporal half, as we can see, there is a fibrovascular pannus that is covering from 11 to 6 o'clock hours with an suspected feeder vessel present here with underlying cataract of nuclear sclerosis grade 3. So the management was a slightly different approach, as we can see in the video. A combined approach was done where there was first wide surgical excision of the fibrovascular pannus was done and excision of the pseudopterygium was done. Then double free stroke cryotherapy was carried out, histopathology was done, and the LSCD, that iatrogenic LSCD that was created, was covered with the help of autologous sled, as the patient had a normal eye in the fellow eye. The histopathology picture showed a mild hyperplasia of the lining epithelium. So definitely it was a mimicker of OSSN. Now post-operatively, how the patient was managed? The patient was managed on moxifloxacin and dexamethasone combination eye drops and antibiotic eye ointment with oral steroids, oral prednisolone, 1 mg per kg body weight tapered over 1 month. At 2 months and at 12 months, so this was a picture at 12 months. There was good ocular surface reconstruction with an underlying nuclear sclerosis, so the vision was 6/18. Coming to a discussion, in the first case, the patient was presenting with OSS and HIV at the age of 56 years. Usually, the age of presentation is around 35 to 41 years. And also, the incidence is only around 4 to 8%. In our case, the temporal limbus was involved, which is also rare. And also, the patient had a unifocal presentation. In our patient, there was a multifocal presentation that was rare. So these were the studies that were supporting. For the second case, ocular surface squamous epithelial hyperplasia, it rarely involves the ocular surface without any definitive triggering event, like no history of trauma, no prior ocular surgery, no ocular surface disease. Hence, it can closely mimic OSSN on clinical examination. And also, our approach to the patient was a combined approach. So it was a rare situation. So conclusion, invasive OSS in elderly male with temporal limbus involvement is rare, but prompt diagnosis and management in immunotherapy can help in saving the patient's eye. Pseudopterygium and coexisting fibrovascular pannus without any significant past history mimicking OSSN is rare. Thank you for your patient hearing.